Now we are going to talk about the treatment of tuberculosis. But first, let's see a little bit of history. In 1944, the first antibacillary treatment, streptomycin, was discovered, but it was given alone, which was responsible of resistance. In 1952, isoniazid, 1966, rifampicin, and from the 18th, we installed the short-term treatment with standardized therapeutic strategies. In the 2000s, we noticed increase in resistance to tuberculosis, what led to the implementation of new drugs last decade. What are the objectives of the treatment? First is to cure the patient while avoiding side effects. It's a prolonged treatment for at least 6 months in order to eliminate all the mycobacteria and to avoid relapse. Also to prevent the death from the tuberculosis and to break the transmission cycle from the contaminated person to the contact persons. We use bactericides treatment in order to eliminate rapidly the mycobacteria and to prevent the development of resistance. We combine a lot of drugs and avoid monotherapy. What are the means of treatment? We have what we call first-line antibacillary, which are 4: isoniazid, rifampicin, pyrazinamide, and ethambutol. The isoniazid is bactericidal, so he kills the bacteria. Rifampicin bactericidal and sterilizing, and those both are the most powerful against the entire population of MTB except for the D. Pyrazinamide is also a bactericidal and he is active against mycobacteria which multiply slowly inside the macrophage. For ethambutol, he is bacteriostatic, not bactericidal, and he is used in combination with other powerful bactericides in order to prevent the emergence of drug resistance, and he could be administered safely for children at the recommended doses. Here we have the presentations of the antibacillars. So they could be given as associated forms or disassociated forms. The disassociated forms, each one's alone, isoniazid, the pills of 300 milligrams and 150 milligrams, rifampicin, pyrazinamide, and ethambutol. And for the combined forms, we could have the combination of rifampicin and isoniazid, the 3 drugs, rifampicin, isoniazid, and pyrazinamide, or even the 4 drugs, rifampicin, isoniazid, pyrazinamide, and ethambutol. Those are the doses for the children that you are going to see in pediatrics. And the doses that we have to give to the adults are for isoniazid, average of 5 milligrams per kilogram, but we can give between 4 and 6. Rifampicin is 10 milligrams per kilogram, but we can give him between 8 and 12. Pyrazinamide 25 and ethambutol 15. Like any treatment, antibacillars can have some side effects. Generally, they become during the first trimester of treatment, but with an appropriate dosage depending on the terrain and with a clinical examination and biological assessment, we can prevent and limit those side effects. Then they can cure at any time of the treatment, so we have to raise the awareness in the patients that they have to consult their doctors each time they have new signs. We have what we call benign side effects. They are often transient. They must be identified and managed locally. They do not require stopping the medication, and mostly they regress either spontaneously or under symptomatic treatment or after adjusting dosages. Do not hesitate to refer the patient to a specialist if these symptoms persist. After giving a symptomatic treatment, if they persist, you have to refer the patient to a specialist. What about serious side effects? Those ones are life-threatening or functionally threatening. They require to stop the drug responsible for these side effects. Certain major effects require the discontinuation of all the drugs. So in this case, we have to refer the patient to a specialist urgently, and the most two side effects that are responsible for these serious side effects are hepatotoxicity and allergic reaction. So, what about the known side effects for each antibacillary? For example, for isoniazid, we know that he could be responsible for hepatitis, peripheral neuropathy, skin hypersensitivity, and digestive disorders. For rifampicin, he could be responsible for hepatitis, digestive disorder, skin hypersensitivity, and some immune allergic reactions. For pyrazinamide, also hepatitis and hyperuricemia, arthralgia, and gout. And for ethambutol, he could be responsible for some eyes problem, what we call a retrobulbar optic neuritis. The mild effects that are known and how to manage them. For example, if a patient presents nausea, vomiting, epigastralgia, and diarrhea, we have to give symptomatic treatment for each one. If he notices that he has dark red urine, we have to reassure the patient that is normal because of the rifampicin. Rifampicin is the medication who can cause that dark red urine. For erythema and pruritus, we give some symptomatic treatment also, like antihistaminics. For a flu syndrome, symptomatic treatments. If he has some joint pains, we give him non-steroids anti-inflammatories. If he had some burning sensations in the feet, we give him vitamin B6. What about the serious side effects? For example, if he has an hepatotoxicity, we have to measure the rates of ALAT, which are the transaminase hepatics. If they are more than 5 rates the normal, or more than 3 times the normal with clinical signs like jaundice, hepatocellular insufficiency, we have to stop all the treatment and refer urgently the patient to a specialist. What are the contraindications of the antibacillars? Each medication has some contraindications. For example, if we have an allergy or hypersensitivity, we have to know what is the drug incriminated and to stop it. If we have severe liver failure, the 3 treatments who could be responsible for it is rifampicin, isoniazid, and pyrazinamide. We have to know what is incrimine the drugs and stop it for well. The gout, the pyrazinamide. So if a person had gout, we do not have to give him pyrazinamide for TB treatment. If he has some visual disturbance, we have to not give him ethambutol. And for persons who are followed for maniac depressive psychosis, we do not prescribe isoniazid. What about drug interactions? Like any treatment, the antibacillary treatment can interact with other treatments. For example, for patients who are taking vitamin B6, the isoniazid can interact with the vitamin B6, so we have to give it far away the isoniazid, no concomitant use. For rifampicin, it is a powerful enzyme inducer, so we have to increase the doses of drugs metabolized by the liver or to change that treatment. For example, the oral hypoglycemics, we have to advise patients even to raise the dose of these drugs or to take insulin during the TB treatment. Antivitamin K, also Digitalis, corticosteroid, cyclosporine, and oral contraception mostly advise the women to change their mean of contraception. What are the adjuvant treatment that we could give in some specific situation? First, we are going to talk about corticosteroids. Corticosteroids, we can give them at the dose of 0.5 to 1 milligram per kilo per day for 6 to 8 weeks if you have some pericarditis tuberculosis, meningitis tuberculosis, highly dyspneic malaria, and significant underbronchial obstruction if it is more than 15%. Also, we can give vitamin B6 as a preventive treatment for persons who are malnourished, alcoholics, diabetics, renal insufficiency, and pregnant women at the dose of 50 mg per day. Sometimes we have to do local or surgery treatment. If you have, for example, pleural effusion, pneumothorax, acids, or cold abscess, we have to do a puncture or even a drainage. We have to go to the surgery if we have a tuberculoma of the brain, bronchiectasis, or an intracavity aspergilloma. What about the practical modalities of the treatment? We have to hospitalize these patients. Mostly, it's an outpatient treatment, so we give the patient weekly his allocation of treatment at the health center of attachment. We do hospitalize persons in some specific situation. If we have a severe form, if we have a severe drug toxicity, for the persons who have an associated TB with the compensated chronic disease, like for example for diabetic persons, if they have ketoacidosis, we have to hospitalize them at the first period to jugulate that diabetic problem. And also if you have some accessibility problems. In case of hospitalization, we have to isolate this patient for at minimum period of 2 weeks because of his contagious. So who prescribes the treatment? If it is simple pulmonary tuberculosis, you can prescribe it. The general practitioner can prescribe it. But for the other forms, it's the specialist who prescribes the treatment. What are the treatment rules? So before giving the treatment to the TB patients, we have to assess the terrain to know if he has some other diseases, if he is taking other medications. We have to define the case according to the Programme National de Lutte Anti-Tuberculose. To give him the regimen according to that program with adequate dosages and to give him some advice about how to take this medication. We have to do a therapeutic education for the patient and for the person who lives with him. The direct supervision was done before, but now we give the patient the medication for a week or two, and we see him after that. And we have to monitor, do monitoring of the patient clinically, bacteriologically, and radiologically, and to know if he has taken good his medication and the tolerance of the antibacterials. So how to assess the children? First, clinical assessment. We ask the patient about his history, the underlying pathologies, the treatments that he's taking, the toxic habits. the biological assessment, all patients who is having tuberculosis, we do a screening for HIV. And in the patients who are known or suspected for a renal failure, we do ask for urea and creatinine. For diabetes, we do ask for glycemia and proteinuria. And in elderly subjects with alcoholic problems and those with liver history, we do assess the liver. We have to define some cases according to the Moroccan program of lutte anti-tuberculose. It's according to the state of tuberculosis. We have to differentiate between pulmonary tuberculosis and extrapulmonary tuberculosis, according to the confirmation, according to the previous treatment, and to the HIV status. So, according to confirmation, we have two cases. Even we have what we call a bacteriologically confirmed tuberculosis or clinically diagnosed tuberculosis. We are talking about bacteriologically confirmed tuberculosis if you have positivity of the biological sample. So if we do a bacteriological exam on the expectoration, even by microscopy, the cultures or the gene expert, and they are positive, at this case we are talking about a bacteriologically confirmed TB. On the other way, if we have a person who has pulmonary tuberculosis and the samples are negatives, we are talking about clinically diagnosed tuberculosis. So the tuberculosis was diagnosed according to some clinical radiological abnormalities or suggestive histology. So even if we do a bronchoscopy and we have the granuloma, we are not talking about bacteriologically confirmed, but a clinically diagnosed TB. And it is the case also for extrapulmonary tuberculosis. If we do not have a positivity in gene expert, we are talking about clinically diagnosed TB. Okay. Now, according to the previous treatment, we could have new case, failure, or relapse. We are talking about a new case when a patient has never received anti-tuberculosis treatment or had received it for less than 1 month sometimes. Those are new cases. For a failure who is a patient who stopped his treatment regimen for a reason, and reasons include no clinical response or no bacteriological response. So he do have the clinical signs, no improvement in the clinical signs, and he do remain positive in the gene expert or in the bacteriology. Persons who had adverse drug reactions that had to stop the treatment and to change it, or an evidence of additionally drug resistance to the drugs in the treatment regimens. So in all these cases, we are talking about a failure of the treatment. Also, we have what we call a relapse. A relapse is a case of tuberculosis previously treated and declared cured or who completed a treatment after a sufficient duration of the treatment and who is now active again for a tuberculosis. So, what are the treatment regimens for adults? If you have pulmonary tuberculosis or extrapulmonary tuberculosis, we give them 2 months of RHZE and 4 months of RH. For the acute and severe life-threatening tuberculosis, like neuromeningeal, osteoarticular tuberculosis, and disseminated and severe form of pulmonary tuberculosis like malarial, we are given 9 months of treatment, 2 first months of RHZE, and 7 months of RH. For patients who abandon the treatment on the relapses with sensitivity to rifampicin, we give them 6 months of treatment, 2 months of RHZE and 4 months of RH. And for failures, Of course, we adapt treatment depending on the response of resistance. Those are the regimen for the children, and as you can see, for some cases we could give just 4 months, but all that you are going to see it in pediatrics. And for neuromeningeal and osteoarticular tuberculosis, we can give 12 months of treatment. So in case of pregnancy, the treatment should not be interrupted. We do have to avoid X-rays except in emergencies, and we have to assess the newborn at birth because there are the risk of congenital TB. So if the newborn have some signs of tuberculosis disease, we have to treat it. And if he do not have signs, we have also to give him the treatment for tuberculosis infection, which is based on isoniazid for 6 months. And these newborn had not to be vaccinated for BCG. So for the breastfeeding woman, none of the antibacillars and contraindicated. So if we have a pulmonary tuberculosis, it is preferable to avoid breastfeeding for patients who are HIV positive or has drug-resistant tuberculosis. Otherwise, the TB woman had to wear her mask and continue breastfeeding. Those are, as we have seen, the doses of antibacillars according to the age. And to be more practical, we gave the doses of pills according to the weight. Those are for children, and here we are for adults. Depending on the weight, the number of pills of RHZE that you have to give him at the first phase of treatment, and the number of pills of RH that you have to give him on the second part of the treatment, depending on their weight.